let's jump right into this explainer. Because today, we're unraveling a truly high-stakes clinical medical mystery. Just picture it. A patient rushes into the ER. They are progressively losing their ability to move, to speak, or even to open their eyes. What exactly is attacking their nervous system? Is it some rare genetic disorder, an autoimmune misfire, or could it be one of the deadliest toxins known to humanity? Today, we're going to untangle the terrifying reality of botulism. And, crucially, we're going to learn how to spot the difference between it and its two biggest clinical imposters, Guillain-Barré syndrome, or GBS, and myasthenia gravis. The details here are absolutely critical, because making the wrong call, well, it can literally be fatal. So think about this. What if you were completely paralyzed but fully conscious, right? It sounds like something straight out of a horror movie, but sadly, this is the chilling reality of severe botulism. The botulinum toxin works by setting off the systematic shutdown of your motor functions. It essentially traps a perfectly healthy, completely aware mind inside a totally unresponsive body. We really have to understand this point. An expressionless face and complete immobility absolutely do not mean the patient is unconscious. Their sensorium, their ability to think, to process, and to feel, remains 100% intact.
And that brings us to this incredibly visceral clinical warning. It reads, "Patient can hear and feel everything. Do not perform painful procedures without warning." We've got to bust this medical myth right now. Just because a botulism patient has bilateral cranial nerve palsies, meaning, they can't move their facial muscles, their eyelids are drooping, they have this utterly flat expression, it doesn't mean they're sedated or out of it. Caregivers literally have to tape signs above the patient's bed just to remind everyone that the person trapped inside that immobile shell is wide awake.
Section 1. The weapon. How botulinum toxin strikes. Okay, so to make sense of the clinical symptoms, we first need to look at the microscopic culprit itself, the botulinum toxin, which is produced by the anaerobic bacteria Clostridium botulinum. This thing is an absolute masterclass in biological sabotage, and the shutdown happens in 3 very specific steps. Step 1. The toxin acts as a metalloprotease. Basically, it acts like a pair of microscopic molecular scissors, chopping up what are called snare proteins. Now, normally, snare proteins are like loading docks that let neurotransmitters leave the nerve ending. So, step 2. Because those loading docks are destroyed, the nerve is physically blocked from releasing a crucial neurotransmitter called acetylcholine into the neuromuscular junction, which leads to step 3. Without that acetylcholine telling the muscle to contract, you get flaccid paralysis. The nerve is literally screaming at the muscle to move, but the message just gets completely cut off. What's truly wild here is just how potent this mechanism is. A lethal dose injected intravenously is just 0.1 to 1 nanograms per kilogram. That makes it one of the most acutely toxic substances known to science. To put that insane number into perspective, an amount the size of a few grains of sand could be catastrophic for an entire population if it was perfectly dispersed. It really doesn't take much of this toxin at all to completely blockade your neuromuscular junctions. Now, when you hear botulism, you probably immediately picture like an old, bulging can of baked beans sitting in a pantry. But the data tells a totally different story. In the US, foodborne botulism is actually only the 3rd most common form. The vast majority of cases here are actually infant botulism. This happens when babies under a year old ingest spores, usually from dust, soil, or even raw honey. And since their little gut microbiomes aren't fully developed yet, the spores just set up shop in their intestines and produce the toxin right there. The 2nd most common form is wound botulism, which lately has been heavily tied to the injection of black tar heroin. So it's really vital to recognize that this threat isn't just hiding in canned food, it's out there in our environment. Section 2, the lineup. Botulism, GBS, or MG. So a patient rolls in weak and paralyzed. How on earth do we prove it's actually botulism? Well, we have to compare our 3 main suspects across 5 key domains: the direction of the paralysis, sensory loss, cerebrospinal fluid, reflexes, and diagnostic confirmation. As a doctor, you really have to put on your detective hat here. You're looking at symptom progression, checking reflexes, and analyzing lab results to isolate the true culprit. Let's break down the biggest differences one by one, because honestly, these are the clues that save lives. Let's zero right in on the absolute most crucial differentiator, symptom progression. Botulism causes a strict descending paralysis. It starts at the top, at the cranial nerves, giving you those drooping eyelids, blurred vision, and a flat face, and then works its way down the neck to the arms and finally the legs, head to toes. On the exact flip side of that is Guillain-Barré syndrome, or GBS, which almost always causes an ascending paralysis. GBS typically starts with tingling and weakness down in the feet and legs and marches its way up the body toward the chest and face. Seriously, if you take only one thing away from this explainer, make it this directional flow. It is the single biggest clue you have in the emergency room. And then we have our third suspect to contrast those two, myasthenia gravis. Unlike the strict head-to-toe drop of botulism or the ascending march of GBS, MG has a really variable progression. It heavily impacts the ocular and bulbar muscles first, so the eyes and swallowing. But the key is that it fluctuates. A patient might actually feel totally fine in the morning, but become profoundly weak by the evening after they've been using their muscles all day. This variable, fatiguing weakness is the hallmark of MG, separating it from the relentless one-way progression of the other two diseases. Okay, let's look at the diagnostics and reflexes, because this is where we nail down our definitive proof. In botulism, the cerebrospinal fluid, or CSF, is totally normal. And surprisingly enough, the patient's reflexes actually remain intact until very late in the paralysis. Plus, an EMG test will show what's called potentiation, meaning if you rapidly stimulate the nerve, the muscle response actually temporarily gets better. Now, contrast that with GBS. Those patients will have elevated protein levels in their CSF, and they lose their reflexes super early on. So, weak patient with zero reflexes, you're leaning heavily toward GBS. Finally, myasthenia gravis also features normal CSF and normal reflexes, but we confirm it through blood tests looking for specific ACR antibodies. So there you have it. 3 different diseases, 3 totally distinct diagnostic fingerprints.
Section 3, the rescue, the race for antitoxin.
The moment botulism is confirmed, the ticking clock revolves around one number, 48. Medical guidelines stress a critical 48-hour window from the onset of symptoms to get the botulism antitoxin, or BAT, into the patient. Administering this antitoxin as early as humanly possible within that window gives the absolute best chance of survival, and it minimizes the long-term severity of the paralysis, because every single hour that ticks by just allows more of those microscopic metalloproteases to permanently snip apart those snare proteins. But we do need to face a pretty stark medical reality about what this antitoxin actually does. BAP prevents progression. It does not reverse existing paralysis. The antitoxin flows through the patient's bloodstream and neutralizes any free-floating botulinum toxin before it can lock onto a nerve. But for the nerves that have already been attacked and blocked, the antitoxin can't fix them. The patient is going to remain completely paralyzed until their body physically grows brand new nerve endings. That's a regeneration process that can take weeks or even months, and it often requires the patient to be kept alive on a mechanical ventilator the entire time.
And get this, the actual type of antitoxin we use depends entirely on who the patient is. For adults and non-infant cases like wound or foodborne botulism, we use heptavalent BAT. It's derived from horses and covers all 7 major toxin types, A through G. But for infants suffering from floppy baby syndrome, giving them horse serum is way too risky. Instead, we use something called Baby Big. This is an incredible human-derived hyperimmune globulin made from antibodies pooled from human volunteers, and it's specifically licensed to safely neutralize the toxin in babies.
As we wrap up this explainer, we really need to step back and remember where this incredible threat actually comes from. The source of this terrifying, highly lethal toxin isn't always a mad scientist's lab or a botched home canning experiment. Clostridium botulinum exists naturally as spores. These are heat-resistant, dormant bacterial structures that are, well, absolutely ubiquitous. They're everywhere, in the dirt in your backyard, in the dust blowing in the wind, naturally resting in raw honey. They're just sitting there, waiting for the right anaerobic environment to wake up and start producing their deadly weapon. Which leaves us with this final, kind of provocative thought. If these invisible spores are scattered everywhere across our soil, our dust, and our food supply, completely undetectable to the naked eye, how fragile is the balance of our own neurochemistry? We walk around every day, moving, talking, breathing, entirely dependent on this incredibly delicate chemical handshake at our nerve endings, a handshake that nature's most perfect neurotoxin, waiting right under our feet, is perfectly designed to destroy. Thanks for joining me to explore this paralysis mystery. Stay curious, stay observant, and never take your ability to move for granted.